Good afternoon, everybody. It's always a pleasure to be here. And everything, I think the Malad Medical Association is making sure that I'm here. Every year, some of them you must be bored of me, but what to do, here I am for one more. So today, I've taken a very important topic again, which is again related to a topic which is very close to my heart, which is the stroke. Especially I will be speaking about ischemic stroke. Today I have taken this name from a very popular serial which used to come when I was a child. I used to see on the Doordarshan. There was this very popular serial. I don't know, some of you must have seen it. This by the name of Different Strokes. There was some the family, American family with Negroes and white kids growing together. It was known as Different Strokes. But today, I will be speaking about strokes in a different sense of manner, in a medical sense of manner, which is our vascular events in the brain, which are known as strokes. So, as you know, stroke is any neurological deficit which comes because of any vascular pathology in the brain. And as you are well aware, there are mainly two types, the ischemic stroke and the hemorrhagic stroke. And more than 75% of the strokes are ischemic in nature. And that is the part of the stroke medicine which has evolved very greatly in the last 15-20 years. So the emphasis of my talk will be predominantly on management of these ischemic strokes, which have undergone a virtual sea change in their management in the last 15-20 years. So I will be coming to them by showing you some representative cases. And one very important announcement I want to make is that there will be some questions which are embedded in this talk, and all of them carry prizes. So all of you who are going to listen to it carefully and answer it, you are going to get a prize which is available at the Wins Hospital stall later on. So please kindly be awake, otherwise you will miss on the prizes. So I will be showing you some cases which will help us to understand the pathophysiology of this ischemic stroke. So before I embark on that, I would like to have you at least some broad basic idea about the vascular anatomy of the brain, because as I am telling you, see, stroke is basically a vascular pathology. Anything which has to do with the blood circulation of the brain, something is going on with the blood circulation. So we have to have some sort of understanding of how the brain is supplied by the blood. So as you know, the brain is supplied by four main predominant arteries, the two carotids, left and the right, and two vertebrobasilar arteries, vertebral arteries, which arise from the neck and from the aorta, and they go and they form what we call a circle of Willis at the base of the brain. So you can see, going back. So there is a, where is that pointer? Okay. So you can see that this is the base of the skull where this circle of Willis is formed, and this is formed by the anterior communicating artery in the front with anterior cerebral artery followed by middle cerebral artery and the posterior cerebral arteries. So they form a sort of anastomosis which takes care of the collateral circulation of the brain. Suppose one of the arteries get obstructed slowly and slowly, then what happens is that the collateral circulation develops from the other side, and patient may remain asymptomatic without any symptoms despite a very high degree of stenosis or occlusion. This is the beauty of the circle of Willis. It tends to maintain the blood circulation of the brain unless there is some acute insult. Then see, after these arteries enter the substance of the brain, there are very small arteries arising from them, which are known as the penetrating arteries, and these especially are very well known in the internal capsule area, which are known as the denticulostriate arteries, and over here, and these are the penetrating arteries which produce what we call the lacunar stroke syndromes. When there is arteriosclerosis, hyalinosis in these arteries, then there is a stenosis, occlusion of any of them, then they produce a classical syndrome which is known as lacunar syndrome. So, uh, the typical strokes, ischemic strokes, can be broadly divided into either a small vessel lacunar infarct, which I just told you, or a large vessel occlusion, when the parent vessel is a large vessel, which is causing this ischemic stroke, like the carotid artery, the middle cerebral artery, anterior cerebral artery, posterior cerebral artery, or the vertebrobasilar system. They can be either embolic, when there is some embolism from the heart or some artery, distal artery, and it gets stuck in that vessel. Or it could be a atherothrombotic process. There is a plaque which has become unstable, and on that unstable plaque there is further formation of a thrombus, and that leads to the occlusion of that artery, which is leading to the symptoms of the stroke. So now let's see a few cases which, at the end of seeing all these cases, you will realize that the manifestation of all these strokes is virtually the same. All of them are presenting with hemiparesis. But you will see later on that how they are different. That is why I have named this talk different stroke. Though from outside, the manifestation will be same in every one of them, but they have different pathophysiology, they have different imaging, and they have, very importantly, most important, different management. That is what I am trying to emphasize. So everything which appears red may not be apple. So this patient, who is a 62 years old female, diabetic and hypertensive, she develops acute onset weakness in the left arm in the last 8 hours, and she is seen by a physician and admitted. The blood pressure is fairly okay, but power is around 3+/5 at the time of admission in the upper limb, and grade 5/5 in the other limbs. So practically there was some weakness only in the upper limb. Apart from that, there was not much other neurodeficit, cognitive functions, etc. were all intact. And when the scan was done, patient was having a small infarct, as you can see in the internal capsule region. So this internal capsule, there is a occlusion of the small vessel which I just showed you, the lenticulostriate branches. Unfortunately, after starting with double antiplatelets, low molecular heparin statins, so power keeps on deteriorating, and the power becomes grade 0 in the upper limb and grade 2/5 in the lower limb. So relatives become very panicky, and I think this is a situation all of you must have faced, especially physicians, etc. It's a very common thing that patient comes walking in the hospital, but later on, even after giving all the treatment, what happens is the patient starts deteriorating. And this lady, unfortunately, developed grade 0 power in the upper limb and grade 2/5. The relatives are very panicky, and the scan was repeated. And what happens? The scan is virtually the same. There is hardly any difference between the first scan. There is no progression of the infarct. Only the infarct has become well defined. So what has happened is that, see, in the internal capsule, all the motor fibers are very present in a very compact area. So even a spread of a ischemic lesion slightly may lead to catastrophic changes in the power without much of a change in the radiology. So that is what I want to illustrate. So this is a patient who has got a lacunar stroke which came initially with grade 2 power and deteriorates to grade 0 within few hours despite starting all the treatment. So this is the lenticulostriate arteries which are occluded in this. Age, hypertension and diabetes are the main risk factors for these in type of strokes, and antiplatelet and statins remain the cornerstone of the treatment. The only thing is that we cannot do any intervention in these patients. It has to be only medical line of treatment, and the patient's relative have to be reassured and the patient has to be reassured. Mostly after some few days or few weeks, they start showing improvement, and they usually have a good outcome unless there are multiple other infarcts also present. Otherwise, they gradually improve. So a lot of reassurance is involved, and we cannot do any sort of intervention in these type of patients. Now let's see a case now, second case. This patient is a 73-year-old hypertensive male with history of ischemic heart disease on double antiplatelets. Present with left hemiparesis for last 1 hour and reaches a nearby hospital, examined by a neurologist. He has grade 1/5 power in the left upper limb and lower limb with a gaze deviation to right, but is conscious and preserved cognition. Patient is having a blood pressure of 190/110. Patient is sent for urgent neuroimaging and reveals an evolving infarct in the right MC territory. See, this is the infarct which we can see. So over here, the right middle cerebral artery, the distal part of the right middle cerebral artery has become involved, and there is a much larger infarct as compared to what we saw in the first case. So now we come to the imaging, the vascular imaging. So you can see the distally, the right MCA is showing a occlusion. Over here, there is arrow, and what you can see over here is that there is a thrombus which is seen in this distal part of the right middle cerebral artery in the plain CT scan. You can also see it in the what we call the SWI images in the. So now we come to the cardinal question now, what should we do now? So here are the options before us. Injection, should we give injection dexamethasone? Should we do a carotid angioplasty? Should we thrombolize the patient? Should we do a mechanical thrombectomy? Any of you? There is a prize waiting for you. What is the right option? A, B, C, D. C. Who said C? C. Dr. S.C. Gupta. So that C is the right answer. So here we have a infarct because which is in the window period. Patient has just come 1 hour with a 1 hour neuro deficit. Okay, whatever time it must have done to do the imaging, etc. Still, it is a patient is in the window period, and patient has an infarct in the distal territory. So not a proximal but a distal occlusion, and looks like an embolic stroke. So this is the one which is most likely to respond to thrombolysis. So the correct answer is first of all to do thrombolysis either by TPA or by tenecteplase. So that is exactly what is done, and patient is thrombolized with TPA after bringing down the blood pressure to 160 by 100 by a labetalol bolus, and within 2 hours the patient starts improving and the patient's power improves. The patient on during the hospital stay is found to have intermittent AF, and the 2D echo reveals a thrombus in the left ventricular apex. So this patient had most likely a cardioembolic stroke which presented in the window period, and because it was a distal occlusion, so patient was thrombolized successfully and patient had a good outcome after the patient had a grade 4 by 5 power in the lower limb and 3 by 5 on discharge, and the patient was put on apexaban 5 milligram BD and plus clopidogrel, and the patient was discharged. The final diagnosis here is left hemiparesis due to right MCA infarct causes cardioembolic stroke because of the AF and the ISD. Okay. Now we come to one more case. Now similar type of manifestation. Now this time the patient is having a weakness on the right side, and this patient has a power of 3 by 5 since last 1 hour with aphasia, and his scan is done which shows acute infarct in the left MCA territory with left MCA occlusion of the M1 segment. BP is normal. So this is how the imaging of this patient is there. You can see there is a large infarct which is evolving over here. This is the what we call the watershed territory, but there is still a lot of area which is spared. But if you see that the artery is occluded quite proximally in what we call the M1 segment, and in the M1 segment you can see that the occlusion is there, and there is a large part of the brain which is still at risk, not infarcted, but is what we call in the penumbra zone, or there is a diffusion perfusion mismatch over there. If we don't do something right now, it is more likely to evolve into a complete MCA infarct. Now this patient is again thrombolized, TPA is given within 2 hours. Despite that, the power deteriorates further and goes to 1 by 5. So we have given TPA, but there is no response. Now again we come to the cardinal question, what should we do now? There is a prize again. So what is the, should we now give injection DEXA, thrombolize the patient again, do mechanical thrombectomy, do a carotid arm? Who was the first? C, green shirt. So that's the right answer. So what we have to do is to go for a mechanical thrombectomy, because what happens is that if there is a very large thrombus load and it is in the very proximal artery, the large thrombus may not get lysed by the TPA or Elaxin, whatever you give, it may not get lysed. It has been shown in large vessel occlusion, only around 20 to 30% of patients get a good reperfusion with chemical thrombolysis. So this patient also did not get good response with TPA, was sent for DSA. It reveals a persistent M1 occlusion and is subjected to what we call a mechanical thrombectomy. The mechanical thrombectomy is a procedure in which a catheter is passed into the artery which is at the problem artery, and then either the thrombus is sucked out, or there is some other different type of devices which have a basket in them. Some have some sort of pulling device through which they pull out the thrombus, or they suck out the thrombus by suction. So this is what mechanical thrombectomy is about. And when the TPA or the chemical thrombolysis has not worked, or if there is a chance that it will not work, then we can go for a direct mechanical thrombectomy also. So this patient undergoes a mechanical thrombectomy. The power improves and becomes grade 3/5 next day. Patient becomes conscious but still has persistent aphasia. Patient is discharged on double antiplatelet and statins. And the final diagnosis in this phase, right hemiparesis aphasia with left MCA occlusion cause atherothrombosis. Yeah, Rajesh, I have not been given time here, 15 minutes only. This bell is ringing on its own. Okay. Maybe I thought I was being subjected to some special treatment. Okay. Now we come to case 4. So here is a patient who has a rheumatic heart disease with atrial fibrillation and presents with sudden onset right hemiparesis and aphasia since last 2 hours. And this patient reaches the hospital very quickly. The stroke team is there. They send the patient urgently for a scan, and within half an hour the report is available, and we get a scan like this. So you see CT is okay, but there is a infarct which is present in this left middle cerebral artery territory. Now with a large left MC infarct, patient is managed conservatively. Anti-edema measures are started. 1 day later, patient becomes drowsy. The left pupil starts enlarging. His CT is repeated. So this is a CT scan which was done next day. So you can see previously the CT was like this, and within 1 day CT has become like this. Patient has become drowsy. Now again same question, what should we do now? We should increase the dose of dexamethasone, increase the dose of mannitol, do the mechanical thrombectomy, do a mechanical, who said D over there? D. So that is exactly what we have to do. So this patient has a midline shift and the pupil is getting dilated. So we cannot wait for mannitol and dexamethasone to work. He's a young patient. What is happening is that there is a tremendous increase in the intracranial pressure, and the patient has developed a midline shift. So in this patient, anti-edema measures are not going to work. A young patient with a large infarct. So then we have to think about something more radical and do something which is going to immediately reduce the intracranial pressure. Otherwise, what is going to happen is that this patient is going to herniate and the patient will die. So basically, we have to do a urgent decompressive craniotomy. So that is exactly what is done. See, you can see that this patient, despite reaching in the window period, was not thrombolized, or mechanical thrombectomy was not done. Why? No. There's a very large area involved. Because see, if you see in this first scan, there is hardly any area which is left. The whole of the territory has become infarcted. So, as you see in myocardium, if it is all infarcted, there is no point in reperfusing, doing any PTCA or any sort of CABG. So that is exactly what is being done in brain. So if we reperfuse this by doing some mechanical thrombectomy also, what will happen is that only we will be reperfusing a dead part of the brain and more likely to get hemorrhagic transformation rather than doing it. So in this patient, instead of doing any sort of mechanical thrombectomy or thrombolysis, we have to do a craniotomy later on to reduce his ICT. And this is the post-op CT, which you can see. And the patient's sensorium gradually improves. He is shifted to a rehabilitation center after 2 weeks with right hemiparesis and aphasia, and patient is put on anticoagulants. This is a fifth case. A 50-year-old male presents with acute onset right-sided weakness for last 6 hours. Symptoms were worst on the onset. They are improving now. Power is around 4+/5. Speech is normal. Now imaging is done. So this is what the imaging is showing. So patient has got what we call a watershed infarct. This is a typical watershed infarct in the left middle cerebral artery distribution. So this patient was further subjected to a vascular imaging, and we can see that this patient is having this over here. So there is a tight stenosis in the both carotid at the origin. So patient has got a bilateral severe carotid stenosis. So what should we do now? As usual, increase the dose of dexamethasone, thrombolyze the patient, do, so it has to be a tie this time, I think, for the prize. So who was the first who said D? I think we'll have to decide, Dr. Dandekar. You have to be more quick. So this patient has, so okay. Okay, we'll settle it later. Please.
I think let's continue with the lecture. There are many gifts, and there are very bigger bumper prizes. So just wait. Picture abhi baki hai.
So this is exactly, so patient has got a very severe bilateral carotid artery stenosis, and patient undergoes a what we call a carotid endarterectomy, in which this stent, carotid stenting, and this what happens is a guide wire is passed again, as I showed you in mechanical thrombectomy, and then a stent is inflated across the origin of the internal carotid, which is going up, and then this plaque which is there is compressed by the mechanical action of the stent, and it opens up and the blood flow is restored. Then serially on the other side also, patient undergoes a carotid the stenting on the other side also later. So patient is this patient is loaded with antiplatelets and full dose statins, and first left carotid is stented after 5 days, and 1 month later the right side is also stented. The final diagnosis, right hemiparesis caused left MC infarct due to artery-to-artery embolism with severe bilateral carotid artery stenosis in the cervical region. In Indians and Asians, there is a lot of intracranial atherosclerosis also, which is very common. But this patient was having a cervical, which patient underwent a carotid stenting. So the purpose of my talk was that to show you that ischemic stroke also is a heterogeneous entity. Recognizing it early is very important. I have been giving a lot of talks about the patients reaching in the window period, how we have to manage these patients in emergency. I thought you must be bored of those talks, therefore I changed the topic today. But earlier also in many of my talks I have emphasized how the patient of stroke should be picked up early, because many of them in the window period when some definitive reperfusion therapy can be done, which can be not only life-saving but also will reduce the neurological disability. Because see, the problem with stroke is not only the lives which are lost, it is the lives which are saved but which become a burden on the family, on the society. So we have to intervene at an early phase so that we can not only save the lives but also bring the patient into his normal vocation, normal activities of daily living. So instead of becoming a burden on their family, they become an active part of their family. So that is what all the stroke awareness programs are about, but that is not the end of the stroke. So there are other things also which we have to understand about stroke. So that is what the purpose of my talk was. So we have to understand That ischemic stroke is also heterogeneous entity. We have to see what is the underlying vascular pathophysiology, because see, as I told you, stroke is a vascular problem. So until unless you understand the vascular pathology, you will not be able to formalize a rational treatment plan. So that is what we have to do by doing imaging, taking a proper history, doing a vascular imaging, and then formulating a hypothesis and accordingly proceeding for the best treatment. Thank you so much.
Thank you, sir, for such a wonderful session. You are a wonderful batsman and you have played your strokes very well. I think the message is very clear. You have to understand the golden hour concept and please save the patient's valuable time by referring them in time so that if thrombolysis is indicated, we can thrombolize the patient and save morbidity, because mortality is one thing, morbidity is also very important. Thank you.
Please don't collect your prizes, and there is a lucky draw at the Winds Hospital stall also. All of you are welcome. Thank you so much.
Thank you, sir.
Malad Medical Association, Dr. Rajesh Jain, congratulations for a wonderful event, and I congratulate all the MMA team. And I used to say earlier, MMA hai, to kuch bhi mumkin hai.
Thank you, sir. Thank you. I request both the chairperson to felicitate our own Dr. Manoj Rajani, sir.